Uh, Good morning, Dr. Bandari. I'm Dr. Saujanya. I'm one of the co-judges along with you.
Hello, doctor. Welcome.
Good morning, ma'am. Yeah, can we start? Is the first person ready? Apurva. FP 1024. This is Hall E, I think we are in the same. Are we in the same page? Hall E, miscellaneous.
Yes, doctor. This is
Yes.
Hall E.
Yeah, can we have the first presenter, please? Apurva. If somebody else is ready also, we can start off. We won't waste time because we are.
Yes, doctor.
Yeah.
Dr. Divakar?
He was here.
Shall I start? Because I have to go for one more session for the chairing. In the next session, I have to go at 12 o'clock.
We'll start, sir.
Okay.
Because exactly at 10:30 or 2-3 minutes early only they have given. We also should.
Okay.
Whoever is ready can present.
Sharing option, who is the moderator?
Hello, doctor.
Sharing I can do now.
Doctor, you have that option. Share screen.
Okay.
Please select share screen. It's showing.
1 minute. One video is there.
Okay.
So good morning, everybody. Today I'll be presenting a case on a study on GDM patients which come to OBG department and retinal changes in the what can retinal changes can occur in the diabetes mellitus we can presenting in this. I think I present the PPT only. I think it is Zoom is not working here. Am I visible?
Yes, sir. Your slides are visible.
Yes, doctor.
Okay. So good morning, everybody. I thank Karnataka Ophthalmic Society for arranging this big conference on the platform, and I thank the chairpersons and for allowing me to present this case study. It is a study of retinal changes in patients suffering from gestational diabetes mellitus. Gestational diabetes mellitus is defined as variable hyperglycemia during the second and third trimester of pregnancy. The study of retinal changes in patients suffering from gestational diabetes mellitus is a subject of this study. This study was done between the months of May 2019 to June 2021. It is a prospective study involving 306 pregnant patients. This 152 were diagnosed and managed as gestational diabetes mellitus patients, and 154 were controls. It is done in antenatal patients attending urban maternity clinic in Bangalore. All the patients selected for study were examined by ophthalmic doctors for any retinal changes after full dilatation. Changes, if any, were recorded in retinal charts and fundus photography. All subjects underwent complete ophthalmic examination, including best-corrected visual acuity, slit-lamp biomicroscopy, intraocular pressure, fundus photography, and OCTA in some cases if it is required. Most of GDM eyes didn't show any clinical retinopathy changes. Thus, whether those GDM eyes have similar capillary abnormalities has not been well studied because of the lack of imaging methods. This study, it was found that only few patients with previous history of diabetes mellitus and some patients who are pregnant for the second or third time had some non-proliferative diabetic retinopathy changes. All these patients were subjected to management protocols as it is done for other patients with non-proliferative diabetic retinopathy changes. The retinal changes, half of the patients with pre-existing retinopathy experienced deterioration during pregnancy. Retinal changes detected as the microvascular changes were closely related to GDM severity and diabetes course. Postpartum, all the patients had partial regression following delivery and returned to their pre-pregnant state by 6 months postpartum. The previous studies reported vascular changes in small vessels, displaying retinal vessel tortuosity, narrowing of the retinal vessel caliber, larger retinal vessel branching angle, and reduced vasodilatority response in GDM eyes. Details of this study are the 306 patients, controls of 154 and GDM 152. 154 controls, there are no fundus changes seen in the diabetic retinopathy patients of diabetic retinopathy, and 152 GDM patients, 37 patients had early NPDR changes, mainly in the second or third pregnancies with the same history of GDM in the previous pregnancies. That comes to about 24%. And 13 patients had early microvascular changes, first trimester pregnant patients with uncontrolled sugar levels, 8.5%. And 1 or 2 patients, that is 67.1%, no fundus changes were detected. Till now, ophthalmologists were called into OBG department for the changes in the hypertensive retinopathy states. In this, the GDM is one of the conditions which has been coming, number of cases are coming now. In the conclusion of this study, we can say, although the exact mechanisms are known, the role of microcirculation has been implicated. The current study provides evidence that the pregnancy state profoundly impacts the distribution of capillary branches from the superficial capillary layer to deep capillary layers. The redistribution caused by capillary dropout changes in superficial capillary layer, which was aggravated by transient hyperglycemic state. These findings contribute to the understanding of the retinal capillary autoregulatory mechanism that facilitates retina to cope with hemodynamic changes under pregnancy of GDM patients. So, thank you. There's a number of patients with diabetic retinopathy in our practice in the type 2 diabetes, but there are only few studies in the literature where the retinal changes have been recorded in pregnant patients. This is an attempt by us to conduct such study after taking informed consent from the patients. I thank all my consultant doctors at Divakar's Hospital, especially Dr. Hema Divakar, who is a senior OBGYN consultant and expert at the national and international levels in the matters related to management of GDM patients. So this GDM is one of the recent conditions which has come across. I think most of us were to go through all these, all the patients with the high sugar levels, we should ask them, OBG people to refer to ophthalmologists for a fundus opinion, because there may be some fundus changes if there are previous history of diabetes is there, or if there are first time pregnancy with GDM like that. So normally we used to get references for hypertensive changes for toxemia of pregnancy. So we can tell gynecologists to refer to ophthalmological opinion for these changes also in future. So this is the main importance for point of this. It is ongoing study, still going on, studies still going on. Thank you.
This is the largest study, I think, 306.
Yes. Previously in China, some studies they have done, China and some other outside. In India, I think this is one of the very important studies.
Florid cases you've seen, sir, PDR like that, where you have
latest changes we have not seen, only early NPDR and background changes we have seen. No
interventions have been done, intravitreal or any laser.
No, only we refer to laser has been done in some cases, because no other interventions we can't do during pregnancy.
Yeah, that's why I asked. Yes.
After the
lasers have been done in some cases.
Yes. Lasers has been done. Most of these patients follow-up is required every year afterwards, because they are prone to develop type 2 diabetes later. So all these patients has to be followed yearly once for fundus examination like that.
Thank you.
Okay, thank you. Dr. Saujanya, you're muted, I think.
Yeah. So I have 3 questions for you, sir. So first question is this a case control study, what you're doing? And second question is, if it is a case control study, how were the controls selected for this particular study?
The controls are those who are not having any history of diabetes or sugar levels are quite normal, and there are no hypertensive retinopathy, no other problems. Such normal patients, normal pregnant patients are taken for controls, and those with variable sugar levels taken for.
What parameters were compared between the cases and controls? Because I
In
didn't.
the cases, mainly we used to check the sugar levels only. In this case, we are not comorbidities were not taken. Only sugar levels were taken, and premies and multi, all the patients were taken actually in both the groups.
Any particular way you have calculated the sample size for this study, or it's a random number?
Because normally GDM percentage is about 10 to 12% in the detected. So according to that, we asked our statistician. He told about 300 patients you can take for 24 months. That is enough. He told. So we took this.
And last question: how frequently were these patients examined? The fundoscopy.
The once in a month when they come for OBG checkup, gynec checkup, I used to examine them in our OPD clinic.
Every time the patient came, an eye checkup.
Once in a month at least. If they come once in 2 weeks, I never used to call them. Once in a month, I used to examine them. That's all, and recorded all the findings.
Thank you, sir. Thank you.
Thank you. Thank you. Thank you.
Next,
Dr.
anybody is
Apurva?
ready?
Okay.
Please share your
Dr.
slide.
Shweta? Shweta?
There is a 6-minute timing. Can we enforce it? 6 minutes, I think. All the speakers, please stick to the time. Who's the next person?
Dr. Kavita, are you there?
Anybody, you can start from last also. Dr. Manishri, Shraddha, Santosh, Aji, anybody. I don't want time to be lapsed because of empty, nobody's talking.
Good morning, sir.
Morning.
Here is my name is Dr. Vanishri. Can I
Yes,
share
yes, go ahead. Share
Thank
the
you.
screen, go ahead.
Good morning, everybody. My topic is comparison of non-contact tonometer with eye care Goldman declination tonometer as a screening tool. Is my screen shown, sir?
Yes, yes, go ahead, ma'am. I can see your screen first. Slide. Move on to the second.
1 second, sir. Introduction. Glaucoma is the leading cause of irreversible blindness throughout the world. Diagnosis of glaucoma is based on structural and functional changes in the optic nerve head. Elevated IOP is the main modifiable risk factor for development and for progression of glaucoma. IOP is the only factor used to titrate the treatment and also can bring about good prognosis and halt the progression. Hence, accurate measurement of IOP is of paramount importance. The following keywords were used in the following study. Objective was to mainly correlate the IOP readings obtained by NCT, eye care rebound tonometer, and Goldman applanation tonometer, and to determine the reliability of NCT and eye care as a screening tool of glaucoma. Methodology, study type was prospective comparative study consisting of 150 patients. Study population was patients attending Department of Ophthalmology in our hospital who had no corneal pathology, and there was no history of eye trauma, and no ocular surgeries in the past. And study period was from October 20 to July 20. Methodology, all patients underwent visual acuity testing, slit lamp examination, IOP measurement by NCT, eye care and GAT, and fundus examination with 90D and 20D. IOP was measured by NCT, eye care and were compared with the gold standard, that is Goldman Applanation tonometer. Results obtained were analyzed with SPSS version 23. As the data was not normal, non-parametric test, Wilcoxon sign rank test was to see the significance difference between the variables. Results showed the following. Firstly, we compared the Goldman Applanation tonometer values with NCT in the right eye, and the mean was around 13.13 plus or minus standard deviation of 3.11, and NCT showed 16.61 plus or minus standard deviation 3.63. So the median was 12.16 with the difference of 3 when compared with GAT and NCT in right eye. In the left eye, when GAT and NCT was compared, again the difference was about 3 mmHg with the median of 12. The GAT was compared with eye care in right eye, which showed almost of around only 1 to 2 mmHg of difference with median of 12 to 40. And in left eye, GAT and eye care comparison showed a difference of only 1 to 2 mmHg with median of 12 to 14, and all tests were statistically significant. Again, the GAT, here the overall values both right eye and left eye were compared. With GAT and NCT was compared, and again the GAT and eye care was compared. And it was seen that NCT overestimated values compared to eye care, and the eye care values were comparable with the GAT values. So results, a non-parametric test of Spearman correlation coefficient has been applied to see the relationship between the variables. And it showed that the GAT and eye care had a value closer to 1, that is 0.09616 in the right eye and 0.912 in the left eye. So there was a greater relationship between the GAT and eye care compared to GAT and NCT, and the tests were statistically significant. This is the scatter plot showing relationship between the NCT and GAT and eye care and GAT. Here eye care shows a greater correlation between the GAT compared to NCT. Again, this is the scatter plot and the values showing relation between the variables. Again, GAT showed a greater correlation with eye care, whereas NCT overestimated the value. Discussion. Mention et al. Study in 2012 showed that eye care showed higher agreement with the GAT over a wide range of IOP compared to NCT. Gopinath GS et al. Study in 2014 showed that eye care gives reliable and accurate readings compared with GAT. From the present study, we can conclude that IOP measured by NCT are significantly higher than GAT and eye care, whereas eye care values are much closer to the GAT values. And as the slit lamp mounted GAT is non-portable and has a learning curve and cumbersome to use for mass screening, and eye care is quick, portable, lightweight, and easy to use and reliable. Our study concluded that eye care can be used as a substitute for GAT for treatment of purpose. Thank you.
Dr. Vanishri, I'm Dr. Saujanya. I would like to ask you 3 questions again. Which test was performed first? Was GAT performed first, or is there any order of doing the tests?
NCT, eye care, and then the GAT.
Okay. Any particular reason? Does performing GAT have an effect on
GAT can alter the corneal surface mount.
Okay. Another question, was inter-observer and intra-observer variation tested in this study? Variation. You're not audible. Vanishri, you're not audible. Vanishri, you're not audible.
Hello, ma'am.
Yes.
I was the only observer, ma'am. So there was no other observer.
Is it important? Is it important to do inter-observer?
There is a difference in GAT due to differences in staining techniques and interpretation.
Okay, so it's probably advisable to do a inter-observer and a intra-observer correlation also. Yeah,
Yes.
thank you. Thank you.
Thank you.
On my side.
Okay, if there is no more questions, we can go for the next speaker. Who's ready? AV team,
Good morning, sir.
So can I present, sir?
what is your name?
Aparna Bhaskaran, sir.
What is your number?
FP 95, third.
What's your name, you said? I can't hear you, man.
Aparna Bhaskaran,
What is the number you said? FP?
995.
You are not in the session, man. This is miscellaneous session, hall E.
The contact lens and
Sir, next session. It is next session starting, sir.
Yeah, you can't present in this session because we are not judges for you.
okay.
You can hold on. Next session, next person, anybody? AV team, please respond.
Dr. Apurva?
Yeah, you are the first. You can present now. Share your slide, please. Can we make it a little quicker? I think I am the oldest in the team.
Dr. Apurva,
morning,
please
sir.
present your.
Good morning, sir. Good morning, sir. Hello. Hello.
Yes, ma'am, you are audible.
Hello.
Please go ahead.
Hello.
Hello, ma'am.
Yeah, we can see, we can hear. Go ahead.
Hello. Hello, I'm Dr. Apurva, sir. Am I audible?
Yes, okay. Yes.
Okay. My study is on perception of knowledge, attitude, and practice towards COVID-19 among patients visiting ophthalmology OPD for admissions and surgery during COVID-19 in a tertiary care center. Introduction. According to the WHO, the outbreak of coronavirus disease has become a pandemic, and the virus has been identified in tears and stools of the deceased person. In view of pandemic, the number of patients visiting hospital for non-COVID diseases was drastically reduced, and only emergencies were seen in our hospital. Since majority of ocular surgeries were elective, like cataract pterygium surgery, national programs conducting camps were totally stopped. So this study aims at knowing the perception of patients towards hospital admission and surgery during COVID-19, and hence the study was taken. Objectives of the study is to assess the attitude, knowledge, practice of the patients visiting ophthalmology OPD for admissions and surgery during COVID-19 in a tertiary care center. Materials and method. Study design was a cross-sectional study. Study period was 14 months. It included the first wave and second wave of the corona, like from April 2020 to June 2021. Study population size was 100 patients visiting opthal OPD during the lockdown. Written informed consent was taken from all the patients, and the study was approved by the ethical committee, and all the patients were given a similar questionnaire which contained the demographic history, education, knowledge about COVID-19, need for visit to the hospital during COVID-19, desire for surgery during COVID-19, safety precautions taken by the hospital and participants to prevent COVID-19. The inclusion criteria were both sexes of all age group, patients with minimal knowledge to read and write, all diseases of the eyes were included, patients willing to give informed consent for the study were included. And the exclusion criteria were illiterates, mentally retarded, emergency cases requiring admission. So the results of the study was, the study included 100 patients, of which 24 were male and 46 were female, and only 48 were above age of 50 years. The main symptom for visit of eye OPD was defective vision, 3 patients, and followed by eye pain and redness in 20%, and others were 37%. So, knowledge in the knowledge questionnaire, these were the results. In our study, 98% were aware of COVID-19, and internet and media being the major source of knowledge, being 50%, newspaper 25%, friends and family was 15%, and government campaign was 5%. And 80% were aware of the cause, incubation period, mode of spread of COVID-19. In attitude, in our study, 60% were aware of the protective measures taken in prevention of COVID-19. 90% were aware of the places to be avoided during COVID-19. 96% were aware of the social distancing. 52% were scared. 30% were stressed about the COVID, and 18% felt hopeless during COVID-19 pandemic. And 50% were not willing for any eye surgery because of the fear of pandemic. 30% were not willing for the surgery because of the cost of the surgery, and 20% were only willing for the surgery. Practice in our study, 66 patients felt that the government is doing their best to stop the pandemic. 34% did not feel so, and 70% agreed with the obligatory lockdown measures by the government. 30% disagreed with it. 75% were willing to take COVID-19 vaccine. 25% were not willing. 65% felt that if proper preventive measures are taken, the global pandemic like COVID-19 can be prevented in future, but 35% did not feel so. Discussion, the study was dominated by male patients, and 48% were above the age of 50 years. The study was done by Rubin et al. Showed similar results. And the use of social media and TV constituted the major source of information about COVID-19. 80% were aware of the cause, incubation period, mode of spread of COVID-19, and a study done by Zong et al. Showed similar results. 60% were aware of the protective measures. 90% were aware about the places to be avoided. 52% were scared, and 50% were not willing for eye surgery because of the fear of pandemic. 70% agreed with the obligatory lockdown measures. 75% were willing to take COVID-19 vaccine. Conclusion of the study is the knowledge, attitude, and practice toward COVID-19 was significantly higher among male literates, media and internet being the major source. Most of the patients took precautions and were following government rules and restrictions to avoid COVID-19. But only a few were willing for surgery because of the fear for surgery. So the study suggests that the population demonstrated decent knowledge, appropriate practice, and positive attitude towards COVID-19 at the time of the outbreak. These were the references. Thank you.
A few questions here. Which part of the state did you do the study?
Karnataka, Bangalore.
Bangalore. Urban, rural?
Urban only.
Oh.
In a tertiary care center.
Oh.
Thank you.
This is which time of the year?
Year from 2020 to 21. Both the COVID waves, first wave and second wave. It was
which month?
April, from April 2020 to June 2021.
Dr. Apurva, you have excluded patients who were illiterate. So don't you think that creates a bias in your selection of participants? Assuming that illiterate won't be much aware of the situation.
Yes, ma'am. So in our result also, it was like more of literates only were there. And that's why
you excluded the illiterates, if I understand right.
Yes, ma'am.
Yeah. So this would obviously create a bias.
Yes, ma'am.
Okay. And among your practice questions,
yes,
practice should be something to assess if the participants were following guidelines, if they were wearing masks, if they were following social distancing. Was that assessed? Because I didn't see those questions.
Yeah, it was assessed, and almost 80% were aware of it and they were following.
Awareness is something else. You've mentioned awareness.
They were practicing.
What is this practicing? Do they follow it?
Yeah, ma'am, they were practicing.
So probably you have not assessed practice. You have assessed again knowledge, whether they were aware of social distancing or not.
Yes, ma'am, they were aware of it.
Yes. So practice, when it comes to a KAP questionnaire, knowledge, attitude, and practice, practice means they should follow protocol. Or how much do they follow what is said is the norm.
Yes, ma'am.
Yeah. So yeah, that's it from my side. Thank you.
Oh, thank you.
Thank you. Next presenter, please.
Good morning, sir. Hello.
Yeah, good morning.
Sir, am I audible? Myself,
Yes.
Dr. Shweta,
Yes.
FP1310.
Yeah, go ahead.
Sir.
Share your slide. Shweta, you can share your slide. Start your.
Yes, sir. 1 second, sir.
AV team, can you help her out? 1 second is too many seconds now.
Yes, doctor.
1 second. I'm not able to share it.
Somebody else is ready to share, then we can come back to you.
I present, sir.
Yes, Santosh.
What's happening?
Hello, Santosh. Are you there?
Yes, ma'am. I'm sharing my screen.
Okay.
FP8.
My slides are visual.
Yeah, go ahead, go ahead. I can see you, I can hear you.
Okay, thank you. My topic for paper is anterior and posterior segment manifestations of pathological myopia. There are no financial interest. Myopia, known as nearsightedness, is one of the most prevalent vision condition caused by mismatch between the refractive power and axial length of the eyeballs and causes the image to focus in front of the retina. Myopia separates into two groups called physiological and pathological according to degree of diopter. Pathological group, a common eye disorder around the world, has myopia greater than 6 diopters. Pathological myopia occurs in approximately 12 to 15% of all myopic population, which corresponds to 2% of general population. In addition, 70% of eyes with pathological myopia have a degenerative disorder in various ocular structures such as cornea, sclera, choroid, optic disc, vitreous, macula, and peripheral retina. Objectives of my study to demonstrate both anterior and posterior ocular segment manifestations of pathological myopia. Method, source of data, outpatient department of ophthalmology. Study design, it is a descriptive observational study conducted from September 2020 to August 2021 for a period of 1 year. Sample size included 150 eyes of 80 patients. Inclusion criteria, all patients with pathological myopia, patient willing to give informed consent. Exclusion criteria, patient with prominent corneal and other lens opacity that could affect the fundus examination. Manifestations of posterior ocular segment associated with pathological myopia such as peripupillary atrophy, myopic maculopathy, peripheral degenerative disorder were recorded. Myopic maculopathy was divided into following 5 categories: absence of myopic changes, that is category 0, tessellated fundus appearance, category 1, diffuse chorioretinal atrophy, category 2, focal chorioretinal atrophy, category 3, and macular atrophy, category 4. Plus lesions such as lacrimal crack, myopic choroidal neovascularization, and which spots were noted. This prospective study included patients who met the pathological myopia criteria, that is refractive error of more than -6 diopter and axial length more than 26 mm. Visited to ophthalmology OPD of Mandya Institute of Medical Sciences, Mandya, between September 2020 to August 2021. Study protocol was conducted following the approval by local ethics committee and informed consent was obtained from all included patients. The detailed ophthalmological examination, including autorefractometer measurement, best corrected visual acuity, which is converted to logMAR, intraocular pressure, measurement with Goldman applanation tonometer, anterior segment assessment with slit lamp biomicroscopy, and dilated fundus examination was performed. Detailed fundus examination was performed using 90D aspheric contact lens and indirect ophthalmoscopy with 20D lens. Axial length and anterior chamber depth measurements were performed using optical biometer. Specular microscope was used for endothelial cell density and central corneal thickness measurement. Measurement of central macular thickness and subfoveal choroidal thickness was performed using spectral domain OCT. The optic disc tilt ratio was estimated on optic disc parameter. It was calculated by dividing the shortest optic disc diameter into longest diameter. A tilted optic disc was defined as an index of tilt less than 0.8. Results: 150 eyes of 80 patients with eye myopia were examined. The mean age was 54.1 plus or minus 14 years. 43 of the patients were female and 90 eyes were phakic and 60 were pseudophakic. And among the phakic, among 90 phakic, the average CCT was 520.2 micrometer, average ACD was 3.02 mm, and average IOP was 16. And among 60 pseudophakic, average CCT was 508.7 micrometer, and average ACD was 3.72, and IOP was 18.2 mm. And in phakic, average axial length is 27.8 mm, best corrected logMAR visual acuity is 0.6, and spherical equivalent was minus 14.25, and endothelial cell density was 2234. Coefficient of variation was 0.36. Percentage of hexagonality average is 44, and radius of curvature K1 38.4, K2 37.7. And in pseudophakic, axial length was 27.6 mm average, and average best corrected logMAR acuity was 0.8. Spherical equivalent minus 2.25. ECD was 2056. Coefficient of variation 0.32. Percentage of hexagonality 38%, and radius of curvature K1 39.4, K2 38.73. And based on axial length, there are three categories: 26 to 27.5 mm. There were 94 patients with tilted disc 47, peripapillary atrophy 80, peripheral degeneration in 28 patients, and posterior staphylomas in 3 patients. And with the axial length of 27.51 to 29, there were 46 patients with tilted disc in 32, peripapillary atrophy in 40, peripheral degeneration in 20, and posterior staphylomas in 30. And with axial length of more than 29.1, there were 10 patients with tilted disc 10, peripapillary atrophy in all those 10, and peripheral degeneration in 9, and posterior staphylomas in 7 patients. And according to myopic maculopathy, there were 57 patients in category 0, whereas 22 in category 1, 10 in category 2, 4 in category 3, 1 in category 4, in among the 94 patients of axial length 26 to 27.5. Whereas among the patients with axial length 27.5 to 29, 7 in category 0, 28 in category 1, 6 in category 2, 3 in category 3, and 2 in category 4. And in patients with axial length more than 29.1, there were 0 patients in category 0. In category 1, there were 10 patients, category 2, 4, category 3, and category 4, 3 patients. And myopic maculopathy was seen in 15 patients among the 94 patients of axial length 26 to 27.5, whereas plus lesion in 2 and peripheral lesions in 28. And among the patients with axial length 27.5 to 29, 11 patients were with myopic maculopathy, 6 patients with the plus lesions, and 24 patients with peripheral lesions. And in patients with axial length of more than 29.1, all 10 patients shows myopic maculopathy changes, 6 patients with plus lesion, and 9 patients with peripheral lesion. Discussion: in pathological myopia, which is referred earlier as malignant or degenerative myopia, a globe progressively extends in the anterior posterior direction. Secondary changes can occur in the globe due to mechanical stretching of the eye structures. As a result of these changes, patient may encounter with visual problems. Conclusion: in conclusion, our study clearly shows that pathological myopia may affect both anterior and posterior ocular segments. However, posterior ocular segment changes are the most important cause of vision loss in high myopic patients. Therefore, patients should be informed about the potential risk associated with myopia. In addition, periodic follow-up is essential for both early diagnosis and treatment of possible asymptomatic ocular findings. These are my references.
Dr. Santosh, one question. Anything new? We knew this since BBS days that pathological myopia causes problem in anterior and posterior. Anything new in your study?
No.
You are just telling that same things are being affirmed by your study. That's all. Or anything new you want to take home message?
There is no take-home message.
That nothing. Just go home. That's all. Okay. Thank you.
Dr. Santosh, you could include few figures in your studies so that it becomes more, easy for us to understand. And there are so many parameters which you have measured. You could have done some statistical analysis also. You could have assessed if there is a correlation between axial length and the pathological changes. So there is a lot of scope which you can do, and you can come out with some good conclusions with your study because you have a lot of data. So you can still work on it, and you can get good results out of this, even though everything is known. As of now, there is no take-home message as you are telling. But probably you can again discuss with the statistician and your chief author, and maybe you can do something about this further. Yeah, thank you.
Okay.
Dr. Sharada?
Good. Hello, ma'am.
Hello.
Who's the next person? Please share your slide and tell your name, please.
Hello, ma'am. Myself, Dr. Shweta.
Okay,
Hello.
you can share. Yeah.
Hello.
Hello.
Yeah,
please share.
ma'am, can I?
Yeah, share.
I'm Shraddha. Hello.
Yes, ma'am.
Ma'am, who should present, ma'am, now?
Shweta, are you there?
Yes, ma'am.
Oh, yeah. Please, please share your screen.
What's happening? Who's?
Shweta?
Okay, next person.
Sharada, are you there? Please share. If you're ready.
1275. Yes. 1275. Yes.
My screen is visible, sir?
No.
Hello?
No.
Hello? Hello?
Yes, you're audible now.
It's visible, ma'am?
Yes.
Go
Please
ahead.
go ahead.
Good morning, everyone. I'm Dr. Shraddha. My chief author is Dr. Shilpa Umarani. My unique code is FP1275. I'm going to present about ocular manifestation in mucor. Introduction. Mucormycosis. Mucormycosis is a potentially lethal angio-invasive fungal infection predisposed by diabetes mellitus, corticosteroids, and immunosuppressive drugs, primary or secondary immunodeficiency, hematological malignancies, and hematological stem cell transplantation, solid organ malignancy, and solid organ transplantation, iron overload, etc. The increasing incidence of rhino-orbitocerebral mucormycosis in the setting of COVID-19 in India and elsewhere has become a matter of immediate concern. Methodology. This is a hospital-based case series study with 10 patients between May 2021 to July 2021 with suspected rhino-orbitocerebral mucormycosis. In this study, 10 cases with rhino-orbitocerebral mucormycosis were presented after purposive sampling was done. Consent was taken from all the patients. Ethical clearance was obtained from Institute's Ethics Committee. After collecting the socio-demographic data of the patient, detailed history will be taken regarding the presenting complaints, paying special emphasis on COVID-19 patient signs and symptoms of rhino-orbitocerebral mucormycosis, duration of hospital stay, requirement of oxygen support, administration of steroid pre-existing comorbidities like diabetes, hypertension, history of immunosuppressive medications like systemic corticosteroids or immunosuppressive. The visual acuity was tested using the Snellen's visual acuity chart. The anterior segment of the patient was examined with torchlight examination and slit lamp, and tonometry was done using non-contact tonometer, and posterior segment examination was done using indirect ophthalmoscope. My results: ocular manifestations were ptosis was present in 5 patients, and conjunctival chemosis was present in 8 patients. Mid-dilated pupil was present in 3 patients. Lid edema was present in 4 patients. Proptosis was present in 6 patients. Restriction of extraocular movement was present in 7 patients, and periorbital edema was present in 3 patients. They were also presented with other complaints like black crust in nasal cavity, that is in 7 patients, then tooth pain and tooth staining, that is seen in 5 patients, fever seen in 2 patients, paranasal sinus tenderness were present in 5 patients, facial swelling and pain was seen in 7 patients, nasal congestion and discharge was seen in 6 patients. Among 10 patients, 7 patients had diabetes mellitus and 2 patients gives history of use of corticosteroid and 1 gives history of hypertension. Discussion: a total of 10 cases were included in the study, out of which 8 had diabetes, 1 had hypertension, and 2 gives history of usage of corticosteroid. It should also be noted that according to one of the previous studies, the risk factors of mucormycosis have shown to differ geographically. In Europe, the hematological malignancies patients were highly prone to the infection, whereas in countries like India, Iran, Mexico, North Africa, and the Middle East, the underlying condition was diabetes. A variety of studies also indicate that there is correlation between site of infection and underlying disease. For example, diabetes mellitus with sinusitis is associated with rhinocerebral disease, whereas trauma leads to cutaneous mucormycosis. Such observation can help the clinicians build a pre-diagnosis judgment. Among all the mucormycosis, rhino-orbitocerebral mucormycosis is most commonly observed in COVID-19 patients during or following COVID-19 treatment. Basic precautionary measures could be followed to control the mortality rates by mucormycosis. Mass awareness could be practiced for visiting the respective clinicians as soon as initial signs of the disease is encountered by the patient. For example, immediately reporting to a dentist if there is tooth loosening without known reason, or visiting an ophthalmologist for sudden blurred vision or ptosis, etc. Strict maintenance of blood glucose level following the treatment of COVID-19 can be a key in prevention of mucormycosis. All the above actions cumulatively can improve prevention, early detection, and outcome. Conclusion of the study: COVID-19 care teams must be aware of the warning symptoms and signs of rhino-orbitocerebral mucormycosis and should give knowledge to patient who is currently under treatment of COVID-19 or follow-up, awareness and due attention to warning symptoms and signs, and should prompt them to seek early medical attention and a high index of clinical suspicion, early diagnosis by a diagnostic tool, initiation of full dose liposomal amphotericin B before culture and histopathology report, surgical and post-surgical management, and oral antifungal and resolution may help optimize outcome of rhino-orbitocerebral mucormycosis in settings of COVID-19. My references are this, ma'am. Thank you.
Okay, your case is 10 cases in this series, no? And did you follow it up for how many days or how many, what's the follow-up period?
I followed up for 3 months, sir.
Oh.
After that, few patients were coming, sir. Few patients are like, they
Out of
don't
10
have any. Sir.
Maximum coming or not coming?
Some 6 patients came back, sir, for 2 months, sir, but few didn't come back, sir.
Okay.
Any intervention was done? Retrobulbar injection or anything?
No, ma'am. Here actually we referred to IR center, ma'am. We sent for debridement, surgical debridement, ma'am, few cases. And here in our institute, liposomal amphotericin B was not available.
Okay, you have studied only the manifestations.
Ma'am, only manifestations.
Okay, thank you.
Okay, sir. Thank you.
Next person.
Good morning, sir.
Good morning. Your name?
Am I audible, sir?
Yeah, you're audible. What's your name?
Am I audible, sir?
Yes, yes.
Can I start?
What is your name? Sweta. Okay. Okay, start, Sweta.
Sir, is my PPT visible?
Yes, go ahead. Sweta, no?
Yes, sir. FP1310.
1 second. This is not matching your.
So the second candidate.
Yeah,
Sir,
second.
this is another session, sir. They have
Session.
mixed up two. This is another session actually.
Autologous serum following pterygium surge accession. That is supposed to be
So the
presented here.
second same
Yes, Sweta?
FP1310, sir.
No, here it's 1105.
Yes, sir, I'm here. Hello.
Yeah. This is not in this session, but next session. This hanging by threads and all is next session.
Sir?
Can you remove the slide, please? Stop sharing. We're not in this session. Yeah, Sweta 1105, you can present. Your pterygium accession.
Yes, sir.
Autografting by autologous serum. Yes, go ahead, please. Share your screen. Yes, you are in the correct hall. You can present now.
Good morning, sir. Here I'm going to present a paper on study of efficacy of conjunctival. Yes, sir. Study of efficacy of conjunctival autografting by autologous serum following pterygium excision. Chief author being Dr. Nimal Kumar Bagrecha. Pterygium is a common degenerative disease with 9.5% to 13% prevalence in India. Conjunctival autografting with fibrin glue, sutures, and mitomycin C is indicated for the treatment, but these adjuncts are having the risk and complications. The recent technique being the autograft fixation with autologous serum, and the results have been comparable with that of the suture and the fibrin glue techniques. Materials and method. It's a prospective interventional study conducted during. Hello, ma'am.
Yes, go ahead. Yeah, go ahead.
Okay.
Slides are not
Okay,
moving.
sir.
Your first slide is still there. Can you move your slides, please?
Sir, actually moved, sir. Second slide.
No, we
Materials
are not.
and methods, sir.
No, it's not there on the screen.
Please select slideshow option.
Yeah, now I can see. Go ahead.
Yes. It's a prospective interventional study conducted during the period 2019 to January 2021. It was conducted among 30 patients with primary pterygium attending the Department of Ophthalmology. We included all the patients who presented to the ophthalmology department with primary pterygium of grade 1 to grade 3. We have excluded the patients with recurrent pterygium, grade 4 pterygium, corneal pathology, and patients with glaucoma, infection, inflammation, coexisting retinal pathology, and cognition factor deficiency. Preoperatively, we have taken the detailed history, and visual acuity was checked by Snellen's chart, refraction, anterior segment was examined with slit lamp, fundus examination, and intraocular pressure measurement. Under peribulbar anesthesia, pterygium was excised, graft size was measured, supratemporal thin graft of about 0.5 mm larger in size was harvested, and it was placed over the base sclera. Hemostasis was achieved, then the eye passed for about 24 hours. Post-operatively, we have given antibiotic with steroids for about 6 weeks in tapering doses and lubricants for 6 weeks. We have followed up the patients for on day 1, 1 week, 6 weeks, and 6 months. On each every follow-up, visual acuity, refraction, slit lamp examination, and condition of the graft was evaluated. Coming to analysis and results, our study included the major age group was between 31 to 40 years, accounting to 30 years patient. 30% of the patient. In our study, 76.7 patients were of females and 23.3% of males. Occupation, majority of the patients were laborers and farmers, according to about 43.3% of cases. 19 patients had pterygium in both the eyes, only one eye which we have been operated. Majority of the patients were in grade 2, that is about 83.3% patients. We have evaluated for the complications, the early postoperative complications, which was noted on day 1, were the hemorrhages, graft edema, graft retraction, graft displacement, and graft loss. Hemorrhage was seen in about 14 patients, which persisted in 9 patients on first week follow-up, and on 6th week of follow-up, there was no any hemorrhage. Graft edema was present in about 10 patients, and it resolved during the first week. Graft retraction was seen in about 5 patients. Graft displacement was seen in 2 patients, for which we have taken for the surgery, and suturing was done for those 2 patients. Graft loss was seen in 1 patient. Late complications being the recurrence, which was observed at 6 months. Only 1 patient showed us with recurrence at 6 months. This is a pre-op pterygium pic. This is post-op day 1. This is 1 week. This is the 6-month follow-up, and this is the pic of 1 patient who had come with recurrence. Coming to discussion, our study was comparable with the other study results. Our sample size was 30. The hemorrhage under graft accounting to 46.7%. It was comparable with the other 2 studies. Graft edema was seen in about 33.3%, which was comparable with Shred Tatte et al. Study, that is 36%. The p-value being 0.5. Graft retraction was seen in about 16.7%, which is comparable to Shred Tatte et al. Study. Graft displacement was seen in 6.7%, and it is comparable to Malik KPS et al. Study. Graft loss was seen in 3.3% patients. Recurrence was seen in about 3.3% patient, which was comparable with Malik KPS study. The p-value of the complications are more than 0.05, and these are not statistically significant. Coming to conclusion, this conjunctival autografting with autologous serum, it is a safe, simple, effective, economical option in the management of primary pterygium. Meticulous dissection is required to harvest a thin graft, that is tenon free graft, and the major disadvantage is the graft instability. These were my references. Thank you, sir.
So dislocation happened in only 1 case out of 30. Yeah?
Graft loss, yes, sir.
Yeah. Okay. This is a good alternative to very expensive glue.
Yes, sir. Fibrin glue.
Yes.
Yes, sir.
Expensive. Now it's coming out in small vials, but still it is expensive for if you open, you have to use it only or you have to group up your pterygium practice accession. Okay.
Yes, sir.
But 30, do you think it's a good number to tell all them? Because others I've seen about 100 or some 80 or little more adding to the better. But this is a good alternative.
Okay.
Thank you.
Yes.
What
Thank you,
happens in cases patients who have got a retracted graft post-operatively at 3 months?
Ma'am, the graft at 6 months follow-up, it was good cosmetically. All the grafts were fine, ma'am.
What you have used, autologous blood or what?
Yes, ma'am. Autologous blood, ma'am.
How did you, like, you punctured any vessel?
No, ma'am. After this pterygium dissection, whatever the hemorrhage was there, that thin blood only. We didn't puncture any blood vessels. The blood was sufficient enough.
Yeah.
The p-value for the complications, what you've mentioned, which is not significant, what is the comparison group for that? Are you comparing with the other studies, or is there a comparison group?
Yes. Yes, ma'am. The results have been compared with the other studies, ma'am.
Yeah, I mean, this is probably something which you shouldn't be doing, because obviously their study would be something different from your study, right? So ideally, you take a control arm, do the pterygium surgery the usual conventional way, and then compare. So that would be a better way of comparing.
No, ma'am, these all studies were conducted, same study, ma'am. Like they've also done the sutureless and glueless conjunctival autografting, ma'am.
Okay. Okay. Thank you.
Thank you.
Presenter, we are exceeding time, I think. AV team, please be a little more faster. The next person.
Dr. Kavita? Dr. Komal? Is there? Dr. Matthew?
Yes, ma'am.
Yeah, you can go ahead.
Yes. Is my slides visible, sir?
Yeah. Go ahead, Dr. Matthew.
Yes, sir. Good morning, everyone. I'll be presenting paper on out-of-pocket expenditure among patients admitted for cataract surgery under DBCS scheme. So, introduction. The National Program for Control of Blindness and Visual Impairment aims to tackle the problem of avoidable blindness in India and to provide the right to sight for every citizen of India free of cost. This scheme is centrally sponsored scheme implemented in a decentralized manner through the district blindness control societies, and the participation of private sector as well as non-governmental organizations is encouraged and made accountable. Hence, any patient with cataract who cannot afford the cost of surgery can get cataract surgery with intraocular lens implantation provided under the scheme of DBCS free of cost. It is paradoxical but true that there could be some circumstances when this patient may have to spend some money in the process of seeking care and to avail the so-called free services. Objective of the study was to estimate the out-of-pocket expenditure and factors associated with it among patients admitted for free cataract surgery under District Blindness Control Society scheme in a private medical college hospital in coastal Karnataka. Coming to methodology, this cross-section study was conducted between the period of 30th January 2019 and 15th January 2020. We included 100 patients admitted for cataract surgery under DBCS scheme. Data was collected using a pre-designed semi-structured interview schedule. Data was analyzed using IBM SPSS version 23 software, with cost being reported as median values with interquartile range, and were compared across categories of socio-demographic and select clinical characteristics using Kruskal-Wallis test. So the three terms used in the study mainly were out-of-pocket expenditure, which included direct and indirect cost during the process of obtaining the services which were covered under the free scheme, and for any additional services which were not covered under the free scheme. Direct cost included medical costs such as investigations, drugs, and any other treatment cost. And non-medical cost included cost of travel, accommodation, and food, which was borne by the patient. Indirect costs included loss of wages of the patient and the bystander due to disease and while seeking and receiving treatment for disease. In results, out of 100 patients interviewed, majority were aged above 60 years, that makes up around 74%, and mean age of the patients was found to be 64.73 years. Age ranged from 49 years to 81 years. Median distance traveled by the patients to reach the hospital was calculated to be 35 kilometers with a range from 1 to 430 kilometers. 62% of the patients did not avail the transport provided by the hospital. Comorbidity was seen among 73% of the patients, with diabetes being the most common comorbidity. Postponement of cataract surgery was seen in 48% of the patients. And median duration of preoperative stay as well as postoperative stay was found to be 1 day. Median total cost incurred by the patient was found to be 1,700 Indian rupees, which included direct and indirect costs. And median direct cost was found to be 1,425 rupees, with interquartile range from 760 to 2,200 Indian rupees. This included medical expenditure, which was mainly contributed by treatment of systemic comorbid conditions. There was no direct cost to patient related to routine cataract surgery in DBCS patients. Median indirect cost included loss of wages of the patient and the bystander, and it was calculated to be 400 rupees. So in this table, you can see that the total cost, median total cost was found to be 1,700, which range from interquartal range from 1,052 to 2,575, and direct cost was found to be 1,425, and a direct cost with only the medical was found to be 600. Direct cost, median direct cost of non-medical was found to be 500 rupees, and indirect cost, which include the wage loss of the patient as well as the bystander, was found to be 400 rupees. Out-of-pocket expenditure for cataract surgery was found to have statistically significant association with the following factors, with p-value less than 0.05. These factors were presence of comorbidity, postponement of surgery, duration of hospital stay, and distance traveled by the patient. Cataract remains the most important cause of blindness and visual impairment among population above 50 years of age. And despite this factor, cataract surgical coverage with persons aged above 50 years in India is around 93.2%. Most of the cataract patients are elderly and have some comorbid conditions. In our study, 73% of patients had at least one comorbid condition which needed medical management, which led to postponement of surgery in increase in duration of hospital stay. In nearly half of our patients, this was the main cause of out-of-pocket expenditure. There was an issue of loss of wages with each day of increased hospital stay. And in our study, the loss of wages for the patient and the bystander constituted 400 rupees, which range from 200 to 600 rupees. In our study, 62% of the patients did not avail the transport which was provided by the hospital. And this may be because they were walk-in patients or choose to come in at a time convenient for them. To conclude, the median total cost incurred by the patient was found to be 1,700 Indian rupees, with major share of which was being contributed by the treatment of comorbidity conditions, and out-of-pocket expenditure of cataract surgery among DBCS patients was associated with the factors such as presence of comorbidity, postponement of surgery, duration of hospital stay, and the distance traveled by the patient. Thank you.
Dr. Matthew, 2 questions from my side. All the patients who bring you do have bystanders, or what is the program in your college?
So all patients are
bystanders, one bystander?
Yes, sir. All patients should have a bystander, sir, especially for getting consents and for taking care of the patient.
And one more question on the campsite, what do? You don't reject patients with comorbidities which cannot be operated. You don't have any small tests to be done in sugar or BP or find out.
Sir.
So
Checking
that you
GR.
can stop the patient from coming into the hospital. Do you have the bus or any transport facilities to bring it to the hospital, or they come by themselves?
So we have outreach camps from where the patients can be brought to the hospital with the college buses.
Yes.
And they can be screened with
screening time. What do you do?
Yes, sir. We check BP as well as blood sugar.
And after screening everything, if you bring it and then increase the day of stay, what is the fun there?
Yes, sir. But some patients who are walk-in patients, they might not be.
Walk-in patients are different. DBC, they are also considered DBCS only, walk-in also?
Yes, sir.
Oh, no. They should come from the same, the Aadhaar card has to match with the same area where you do camps.
Yes, sir. But they may be coming after the camp is over on a different date, sir. So without the transportation, they'll be coming as walk-in patients.
Facilities available in your college.
Pardon, sir?
This walk-in facility also is available in your college.
Yes, sir.
Okay. Because that is not considered DBCS if anybody walks in that way.
Yes, sir, but they would have been screened in the camp also.
Yeah, we do 200 surgeries in camp in our college, and we screen them very thoroughly so that we don't take patients and treat them. There's no admission facilities for treating diabetes and hypertension.
Yes, sir.
That's the protocol. You can reduce the complete, and bystander only for bilateral mature cataracts. Otherwise, no bystanders. You can reduce the cost that way. Okay.
Yes, sir.
Dr. Bandari, I have a conflict of interest in this presentation.
Yes.
He's from my college, so I won't be marking him.
Okay. Okay, no problem. You just write in your marks sheet that.
Yes.
Thing. Just note that.
Yes.
Thank you, Dr. Matthew. Yeah. Next person, please.
Dr. Haji? Are you there?
Yeah, I am here.
Okay, please go ahead.
Okay. Are my slides visible?
No.
Dr. Kavita and Dr. Komala, please ready for next presentation.
Dr. Haji, you are there? What's happening?
Yeah, yes, sir. Yes, sir.
Yeah, you are there, but the slide is not there. Yes, go ahead.
Okay, sir. Good morning, everyone. My topic is analysis of combined tarsography with lateral canthotomy in patients with acute onset proptosis. Starting with introduction. The patients with acute onset proptosis pose a unique challenge with respect to management.
Slide is not moving. It is still in the first slide. Slide show F5.
Is it moving now?
No, it's still in the first slide only. The introduction slide is not come out. Now it's gone.
Okay, sir.
Go ahead.
Patients with acute onset proptosis pose a unique challenge with respect to management. They need to be carefully evaluated and managed to prevent blindness. Secondary to optic nerve compression and exposure keratopathy. Tarsography with lateral canthotomy prevent complications secondary to exposure keratopathy and relieves increased orbital pressure. So this combined primary emergency procedure can be performed bedside for those patients awaiting orbital decompression. Objective: to analyze the outcome of tarsography with lateral canthotomy as an emergency bedside procedure in patients with acute onset proptosis. Methodology: study design is retrospective case series analysis. Sample size 6 consecutive cases. Duration of study was 6 months from Jan 2021 to June 2021. So we analyzed the outcome of tarsography with lateral canthotomy in 6 patients who presented with acute onset proptosis due to various causes. All 6 patients had signs of increased intraorbital pressure with severe chemosis which threatened optic nerve. All these patients could not be taken up for primary orbital decompression surgery due to high risk systemic status. Therefore, bedside primary emergency tarsography with lateral canthotomy was planned under Van Lint block under aseptic precautions. So the Van Lint, the first images of the Van Lint block. In this technique, about 3 to 4 ml of lignoplane plus adrenaline was injected, introducing 26 gauge needle about 1 centimeter below and behind the lateral canthus, along the superolateral and infralateral orbital margin in the V-shaped manner. In this second image, we can see the lateral canthotomy being done. In the lateral canthotomy, hemostat is usually used to crush the tissue from the lateral canthus to the rim of the orbit about 20 seconds to 2 minutes. The crushing the tissue helps in minimizing the bleeding. So once the hemostat is actually achieved, then by using the scissors, cut is actually made from the lateral canthus to the rim of the orbit for about 1 to 2 centimeters. Then the inferior crust of the lateral canthal ligament is actually cut by actually lifting the lateral portion of lower eyelid. And if the IOP is still high, then the superior crest is actually cut by lifting and exposing the underside of lateral upper eyelid. Now, temporal tarsography. In the case of the temporary tarsography, the 2 bolsters of usually we use the plastic tubing of 2 to 2 centimeters to 1 to 1 centimeters. In this, the suture is actually passed through the bolster, followed by the upper eyelid and then the lower eyelid, and then the second bolster. Once the second bolster is actually engaged, the suture is turned around and placed through the lower eyelid and then the upper eyelid and the bolster. The suture is then tied to the complete the tarsography. The results: out of 6, 4 patients had acute proptosis secondary to thyroid eye disease. One had secondary to the olfactory neuroblastoma with intracranial extensions and nodal metastasis, and last due to the orbital lymphoma. Then out of the 6, 4 patients showed reduction in intraorbital pressure and chemosis with stabilization and prevention of exposure keratopathy. Over the next 2 weeks, all 4 patients underwent orbital decompression and showed good recovery. So in this figure, the case 1 actually, we actually sees case shows the bilateral acute proptosis. And when the emergency procedure of lateral canthotomy with tarsorrhaphy was done, the patient was again analyzed after 3 days, showing the significant reduction in the chemosis as well as the intraocular pressure. In case of the case 2, which where we had who had the proptosis secondary to neuroblastoma, the significant improvement was actually shown after doing the canthotomy with tarsorrhaphy. Now coming to the discussion, acute proptosis is defined as a condition wherein protrusion occurs over several minutes, several hours or 1 to 2 days. The common causes includes orbital emphysema, orbital hemorrhage, acute severe thyroid eye disease, the fracture of medial orbital wall, rupture of ethmoidal mucocele. The patients with acute onset proptosis must be carefully evaluated so as to find the underlying disease causing proptosis, and early management helps in providing symptomatic relief and preventing and treating the visual threatening complications like orbital compression syndrome and exposure keratopathy. Tarsorrhaphy with lateral canthotomy can be performed as an emergency bedside procedure with simple instruments in the patients to prevent exposure keratopathy and blindness secondary to the optic nerve compression. In a study conducted by Adam D. Rowe et al., it was found that lateral canthotomy being performed as an emergency bedside procedure helped in providing the symptomatic relief to the patient and decreased in the intraocular pressure. However, in our study, most of the cases of acute proptosis were secondary to thyroid eye disease. Patients showed similar recovery pattern following the tarsorrhaphy with lateral canthotomy as shown in the study conducted by Adam D. Rowe et al. Conclusion, tarsorrhaphy combined with lateral canthotomy can be considered as tarsorrhaphy combined with lateral canthotomy can be considered as primary bedside procedure in patient with acute onset proptosis and awaiting clearance for orbital decompression. Thank you.
How many cases is in your study?
We studied 6 cases, sir, out of which 4 presented with acute onset proptosis secondary to the severe thyroid eye disease, and 1 was secondary to the neuroblastoma, and 1 was secondary to the orbital lymphoma. Out of the 6 cases, 4 was followed and showed the recovery, sir, but 2 patients actually expired after the, following the canthotomy and tarsorrhaphy. They had a high systemic high risk status, so they expired.
Not because of procedure, please don't tell that.
No, sir. Okay.
Because of a systemic problem.
Systemic problems.
Have you followed them up for the intraocular pressure and vision?
Yes, ma'am.
Okay, thank you. Next presenter, please.
Thank you, sir.
Dr. Kavita, are you there?
Yes, ma'am.
Okay.
I'll share the screen, ma'am.
Okay, sure. Go ahead.
Ma'am, is my slides visible?
Yes.
Go ahead. Yes.
Is it moving, ma'am?
Yes, moving.
So I'll be talking on ocular abnormalities in children with developmental delay, aged between 1 and 18 years. We have no financial interest in this presentation. As we know, a significant delay in the acquisition of milestones or skills in 1 or more domains of development, example, gross motor or fine motor, speech or language, etc., is defined as developmental delay. A significant delay is defined as discrepancy of 25% or more from the expected rate. Ophthalmic disorders are common in all these children, and knowledge of their visual problems is essential if these children are to be given optimal support. Assessment and management of visual deprivation in these children is a complex challenge. So our aim was to describe the presence of ocular abnormalities in children with developmental delay aged between 1 and 18 years. And our objective was to analyze the risk factors and systemic associations that may be contributory to delay in the development and the possible treatment that can be delivered in these children. This was a cross-sectional study of 94 children between September 2017 to October 2019. We obtained approval from the Institutional Review Board and got the informed consent from parents. We included patients with developmental delay diagnosed by pediatrician and/or neurologist in the age group between 1 and 18 years. We excluded those children where the parents didn't give informed consent for dilatation. So ocular complaints, detailed birth history, family history, and neuroimaging findings were noted from the case sheets that they brought from the pediatrician or neurologist. Wherever possible, we evaluated the uncorrected and best corrected visual acuity based on visual acuity charts where it was possible. In other children, we used the visual behavior and fixation pattern. Other eye findings were noted. Dilated refraction, care was taken to use tropicamide drops or ROP drops, and punctum occlusion was advocated in every patient. Anterior and posterior segment findings were noted. Glasses and low vision aids were prescribed in those children who were able to handle. Amblyopia therapy was advocated if applicable and possible wherever. Vision stimulation exercises was advocated in corticovisual impairment children and delayed visual maturation children after the diagnosis was made. Surgical correction was advised wherever required and feasible. Data was described or analyzed in descriptive manner. Corticovisual impairment was defined as a child having decreased visual response, normal ocular examination, but abnormal neuroimaging findings. On the other hand, delayed visual maturation was a diagnosis was made if there was decreased visual response, normal ocular examination, and neuroimaging findings. So coming to results, male was preponderant sex, and the mean age was 4.9 years. Both uncorrected and best corrected visual acuity was more frequently, we found that it was fixating and following light, about 70 children. Coming to ocular abnormalities, 83 children out of 94 children had ocular abnormalities, one or more, and we found refractive error most common, being seen in 70 children, followed by strabismus in 39 children, nystagmus in 22 children. And as regards to posterior segment findings, optic atrophy was the most common finding, followed by other coloboma and other defects. Amblyopia was seen in 16 children, delayed visual maturation in 13, and corticovisual in 11. Coming to risk factors, systemic disorders, and neuroimaging findings, we found abnormal antenatal history like diabetes, hypertension, oligohydramnios in 6 parents, mother. Consanguineous marriage was the most common finding in 27 children. And as regards to children, it was low birth weight, and NICU admission was seen in 19 children, and epilepsy in 24. And abnormal neuroimaging was found in 47 children, and the most common finding was gliotic changes. We advised visual stimulation in 65 children, glasses in 39. LVA was tried in 3 children. Occlusion therapy for amblyopia was advocated in 12. Cataract and squint surgery was advised in 5 and 3 children respectively. So the various studies both in India and outside. Outside India, the common ones were the Chang et al. And Nelson et al. Study, where specifically they dealt with developmental delay children. In India, few of the studies, they catered to cerebral palsy, learning disability, and they did analysis of children in specialized school. We found that refractive error, like in our study, which was 74%, correlated with Sabita et al. Study, where they found it was 67%, but they did the study in cerebral palsy. So strabismus was found in 41% in our study, whereas in Sabita et al. It was 39%. There's a review study brought out by Meenakshi Swaminathan, which only analyzed about how to go about assessing vision and ocular examination in these children. Recently in 2021, Vidya Hegde et al. brought out an article about the importance of evaluating ocular findings in children with developmental delay, and they found 85% had ocular problems, which definitely necessitates the need for ocular evaluation. Sheila Devi et al. Study actually brings out that refractive error in normal children is about 8%. So it is much higher in developmental delay children. So to conclude, our study had 88% of ocular problems in developmental delay children. Refractive error being the most common, constituting about 75%. We do regularly school screening in government, private schools, and schools in rural and urban areas. But so far, we have not done specifically on in rehabilitation centers. Whatever we analyzed is from referral as a reference. And one more limitation is that we have not graded the developmental delay, and neither it was a longitudinal study because we could not follow up these children. They wouldn't come for follow-up. So finally, we thought that this study brought out the importance of screening rehabilitation centers and creating awareness amongst healthcare workers and general population, so that an integrated approach in early diagnosis, appropriate management, and analyzing the risk factors and prevention. This would be, this study would help us so that there is an overall development in these children. Thank you. These are my references.
Ma'am, how many patients are lost for follow-up, or all of them are lost for follow-up?
No, sir, not some of them. Actually, this is just to be considered as cross-sectional. I didn't, in this study, I didn't bring out the longitudinal data.
Okay, good study.
Because they wouldn't come for follow-up, sir, because we will tell vision stimulation, or right now we can't do anything much. So they never come back when we tell them to come back after 4 months. When we are advising vision stimulation, we can see improvement in 4 to 6 months, sir. The child who will not respond to light the first visit, when we advise vision therapy, that is light stimulation, then we can see the difference when they come for second visit. There is an appreciation of light from the child. This even the parents will tell.
These are patients in the outpatient or from the rehabilitation center, ma'am?
Sir, these patients are actually referred from pediatrician and neurologist, and pediatric neurologist specifically, sir, referred patients to our center.
Okay.
Very well performed.
Okay, thank you.
I mean, congratulations to the whole team.
Thank you.
Probably another follow-up study would be very much useful and very much necessary in this area.
Ma'am, we are doing it, ma'am, but for paper, because the dropout was much more than what we wanted the results to, we should get some results, no, ma'am. So the follow-up was very long follow-up. If you tell 4 months, they might come after 2 or 3 years. But in that, whatever I have analyzed is that there is some optic atrophy patients, some of them respond spontaneously also without stimulation. So that is also there, ma'am. In some children in whom we would have assessed as low vision, very, very low vision. After 4 or 5 years, they come, we have seen improvement, spontaneous improvement in vision. They don't come for follow-up because we are not giving any magical vision by giving that vision stimulation, ma'am.
Probably increasing awareness is something.
Yes, ma'am. Yes, ma'am. Because one more finding which I have found is that the pediatricians or neurologists, they will have, if they have a physiotherapy unit, they will take up these children, ma'am. And these children, as when I spoke to the physiotherapist, they told adult physiotherapy is easier, much easier. But children physiotherapy, even in normal children physiotherapy, is very difficult. So then I analyzed that children with developmental delay, we should have a lot of patience in bringing about even minute difference like moving a finger or moving the forearm or lifting the forearm or like that. So for the parents, the motor facility, that is limb movement, is more important than eye. So they don't come for follow-up. This is what I have analyzed over the period of time. So I felt there should be an integrated approach. Maybe the government, we should take up this initiative.
Thank you, Dr. Kavita, ma'am. We are running out of time. We are One more person.
Thank you, sir.
Dr. Kavita, one question for you.
Yes,
If
ma'am.
you followed up those majority you corrected given the refractive correction, so those patients, there will be an improvement in their IQ also. That's
Yes,
what we
ma'am.
have also done in our CVI clinic. There will be a
Yes,
lot
ma'am.
of improvement.
Yes, ma'am. Yes, ma'am. The parents give the feedback, ma'am.
Yeah. Okay.
Thank you, ma'am. Thank you, ma'am.
Dr. Komala, are you there?
You can hear me, ma'am?
Yes.
Hello, ma'am?
Yes.
This week, I'll share the screen, ma'am.
Okay, sure.
This is my paper on visual implications following online classes in medical students during COVID times. My chief author is Dr. Abu Ghatur. Introduction. In the COVID-19 pandemic, which has left the globe, has had a notable impact on the lives of the students with unpredictable developments unfolding every day. And
Sorry
there
to
has been
interrupt, Dr. Bandari, I don't think this is the paper.
One second.
Ma'am?
Can you tell your...
Yeah, FP 907.
07. Yes, ma'am. It's a paper, ma'am.
Yes, same paper. To evaluate the use of
Evaluate digital devices, reading habits, and prevalence of eye strain.
among medical students.
Among medical students during COVID times.
Continue.
During COVID-19 pandemic, there has been swept the globe, which has been notable impact on the lives of students with unpredictable developments unfolding every day. There has been a lockdown in multiple countries on an unimaginable scale. Individuals who spend long periods looking at computer display have intense accommodation and the exocular strains and often exhibit asthenopia. Although positive impact also is there on cognitive development and academic skills, which have been found with negative influence on psychological and social skills, we are aiming to find out ways on which risk is attached with the high screen time on digital devices on medical students' eye with imitated and reduced. Aims and objectives mainly to evaluate the use of digital devices, reading habits, and the prevalence of eye strain among medical students aged between 22 to 28 years. Materials. This study included 157 medical students attending online classes by using electronic device via the questionnaire. Additional information also on the factors and the effect on ocular symptoms was collected. This was the questionnaire which was given to the students, how they spend on reading the paper or book and how many hours do they spend and what device do they use and how often do they use in a week and the distance with which they read or use the electronic device and the posture while reading and the devices which have been used and do they get eye strain at the end of the day and if the student has been using glasses or not and if there are any frequent change of glasses in the recent times and they when they use smartphones during bedtime and following which the symptoms ocular as well as systemic whatever they suffered following online classes. Results, males have been 52%, females are 48%. Reading habits, using digital devices, among 96 students have been using iPhone or smartphone. 28 iTab or tablet has been using. And students, 24 students are using desktop or laptop. Reading distance, 108 students use at a distance of 25 to 40 centimeters. 19 students use at an arm's length of while reading, and 29 students at a distance less than 25 centimeters. And this is a table showing books as well as digital devices with how many hours do they use, like less than 2 hours, 2 to 4 hours, 4 to 6 hours, more than 6 hours. And do they get eye strain? 59% said no, whereas 41% said yes. Comparison between the posture in sitting in a chair, students were like 125 students. When lying on bed using online devices, 32 students were noted. And this is a table showing ocular symptoms as well as systemic symptoms. Redness in 15 students, watering in 28 students, blurring of vision in 31 students, burning sensation in 20 students. Systemic symptoms like depression in 26 students, headache in 72 students, irritable 30 students, not sure among any of the symptoms is 43, sleep disturbance in 39, and tired in 61 students. This table is showing time spent on using digital devices 1 to 2 times a week, 21 students, 3 to 4 times a week, 17 students, 5 to 6 times a week, 28 students, 8 to 9 times a week, 4 students, every day 91 students. Discussion: in my current study, 59% of the students present with typical eye fatigue symptoms had ocular with examination aged between 20 to 28-year-old. Also presented with refractive errors and low visual acuity. And the studies show 115 students use smartphone on bedtime while switched off lights. And the use of smartphones at bedtime with lights switched off also increased. Conclusion: as we have noticed in my study that the use of electronic devices and their elimination using their usage, following measures can be taken to prevent their impact and limit the screen time. Also avoid the use of electronic devices outside and in bright environments, as glare can produce unnecessary eye strain. Remind the college students to blink frequently and prolonged usage of digital devices. And ensuring a good posture while reading and using electronic devices, holding the digital device at least 18 to 24 inches farther away, and to encourage reading books rather than e-books. These are my references. Thank you.
Mode of data collection.
I gave questionnaire, ma'am, to the students. Which I showed prior. Based on what they have marked in that questionnaire, I have got the results. This was the questionnaire was given to the students.
Any dry eye test or anything you have done?
No, sir. It was just observational, sir. Whatever they have answered to the questionnaire, based on that, I have concluded the results, sir.
Oh. Oh.
Is there a possibility of underreporting in your study?
Ma'am?
Is there a possibility of underreporting? I will say that I use laptops or mobiles for 10 hours a day, but I will say that I use only for 2 hours. Is it a possibility?
Possible, ma'am. Possible, ma'am.
That should be one of your limitations. And have you tried to validate your questionnaire?
Means concluding the results, ma'am?
No.
Validation.
Validation of this questionnaire. There is something called as a content validation, construct validation.
No, ma'am.
No. Thank you.
No.
Okay. Thank you.
Next.
Okay, we'll finish the session. We are 10 minutes late. We have been given 5 correct time when we took over. Thank you very much, Sojanya ma'am, and
thank you. Thank you, ma'am.
Yeah.
Thank you,
We'll
doctor.
upload the reports to the email. Thank you.
Okay, doctor. Thank you.
Thank you.
Thank you all.